All right, we're going to talk about cleft lip and cleft palate, as well as hypertrophic pyloric stenosis. Okay, so with cleft lip and palate, we can have one or the other, or both. The pathology, the pathophysiology is basically that it's an incomplete fusion of the lip or palate in utero. So this is considered one of the different neural tube defects that can occur during pregnancy because of a folate deficiency. Um, so the risk factors for cleft lip and cleft palate or cleft palate are being born with any other syndrome. Most syndromes have a multitude of different body systems involved in them, and cleft lip and palate are things that we can see frequently in children born with Down syndrome, children born with, I think it's Dandy Warburg Walker syndrome. There's various other syndromes that we can see this in. All of the trisomies, it tends to be very common. Another risk factor is believed to be the maternal risk factors and environmental risk factors. So there's not complete proof yet that any maternal or environmental exposures definitively cause this, but they do see a link, although it's vague. So we're going to say smoking, drug use. One thing that they do know for sure is that the use of very old school anti-seizure meds and some antipsychotics does increase the risk of cleft lip and or palate. So like phenytoin can be a really big risk factor. That use during pregnancy to treat maternal seizures can cause this. Folate deficiency I already mentioned. So some of the cues that we're going to look for is if it's a cleft lip, we're obviously going to be able to see it. It's not going to be something that would be missed very frequently. So there can be on a cleft on either side of what we call our Cupid's bow, your cute little bow at the top of your lip. It can be on either side or it can be on both. So you can have a unilateral cleft or a bilateral cleft of the lip. When we're looking at cleft palate, that can occur as well by itself or as a combination with the cleft lip. So when you see the nurse after delivery stick their gloved finger into the baby's mouth, they're not checking for suck, they're checking for a hole or deformity in the palate. Some of the hypotheses that we want to prioritize for the cleft lip and palate child is airway management, obviously. And some of these are hypotheses that we would use post-operatively because in a lot of cases, although we think of cleft lip as being something that is just cosmetic and aesthetic, a way that we want our child to look and they can function with a cleft lip, a cleft palate is not really compatible with growth and nutrition because it's going to allow food contents into the sinus cavity and then cause a lot of aspiration. So we're going to look at airway management, promoting adequate nutrition. We also want to really focus on parental bonding and emotional support. This can be very traumatic for a family to go through, and it can come with a slew of other problems. So having to have your child evaluated for different syndromes or genetic issues, as well as being concerned whether or not they're going to appear what we would consider normal and beautiful as they grow, and also if they will even be able to function appropriately and gain enough nutrition and learn how to eat. So I do want to let you guys know that with a cleft lip, we can actually feed pretty easily. Those children are perfectly fine breastfeeding, and actually they probably do a little bit better than their quote unquote normal counterparts, because the way that if there is a cleft in the lip, it allows for more expansion of the lip onto the breast tissue. And we like to have the lips over the top of the areola so that we can get a good seal. And a cleft lip infant is able to do that easier than an infant without one. However, a cleft palate, they might be able to get a good grip and grasp on the nipple, but they will likely aspirate the formula or the breast milk into their airway. So they have to have specialized bottles. We can use like a palate block and allow them to do some breastfeeding that is assisted, usually because we want to make sure they get good nutrition and caloric intake when they're newborns. All of this is going to also impair the bonding and the emotional status of the parents. So keep that in mind. The medical management that's required for a cleft lip and palate. Surgery for the cleft lip is done between 2 and 3 months. You might find a slightly different time period in your textbooks or in another textbook, like maybe ATI versus the Ricci text has a slightly different range of time, but the cleft lip's always done very early because it's easy to get it fixed and done when a child is able to be restrained a little bit more and they can't pull at or rub off their sutures. So cleft lip repairs at 2 to 3 months. The cleft palate repair has to be done much later in life. So it's usually done between 9 and 18 months. We do them frequently on children from other countries where the surgery is not available for them, and we see those children coming in at older ages to have lip and palate repairs. And they're usually not super healthy because they're not getting adequate nutrition. So 2 to 3 months for cleft lip repair, 9 to 18 months for the cleft palate repair. Some of the interdisciplinary care that we need to think about with a child who has cleft lip or palate is we need to have dental involved, we need to have speech therapists involved, we need to have the dietitian and the nutritionist. We're also going to defer heavily to the occupational therapist. They're going to come in to the NICU or the pediatric area. They're going to do suck and swallow evaluations on the patient, and they're going to leave us with a beautiful little printed out list of all of the requirements and recommendations that they have for which bottles need to be used, what type of feeding, in what position, and what formula or additions to the breast milk they might have. So we want to really focus on what the OTs tell us to do because they're the experts there. We obviously need to have surgeons involved, and we need to have pediatricians involved. Sometimes it's really helpful to get social work involved, just to be able to help to manage the parents' expectations and to provide them with some resources outside of the hospital setting. All right. So now we're going to talk about hypertrophic pyloric stenosis. So you can see from the pictures your esophagus, it goes down into your stomach goes, the food goes through the pylorus, which is a sphincter. It squeezes a little bit, and then through the duodenal tissues, and then into our guts, you know. So with hypertrophic pyloric stenosis, everything you need to know about it is in the name, right? It's hypertrophied, so it is thick and overgrown, and it's stenosed. It's become hardened. So when the infants are born, they're able to take in, 5 to 10 mLs of fluid at a time, and that's just a small enough amount to make it through this hypertrophied, hardened stenotic area. And then as they start to need and require more foods, um, they develop a lot of vomiting because there's too much in the stomach. It can't pass through the stenosed area and it comes back up. So the risk factors for developing or being born with hypertrophic pyloric stenosis is they assume some genetics, because sometimes we do see this run through multiple siblings in a family. It usually happens to the firstborn male. Why? We're not sure. It is usually occurring within the Caucasian ethnicity, and we see it usually starting around between 2 to 4 weeks of age. So anywhere from 2 to 3 weeks old is when they're starting to really ramp up the amount of intake that they have. And that intake is going to get trapped in that little stomach, and they're going to start vomiting. And it is non-bilious projectile vomiting starting to occur within the 2nd and 3rd weeks of life. So that non-bilious projectile vomiting is a huge cue and an NCLEX pearl for you, as is a hard, movable, usually 2 to 3 centimeter olive-shaped mass that sits right above the epigastrium, which is in the right upper quadrant, slightly to the right, just bloop, right to the right. And if you look at these babies, they are usually very irritable. I say usually a lot. I am sorry. Usually I don't do that. I'm just kidding. So these babies are very irritable because they are just starving. They are so hungry, and their little bodies are kind of wasted. They tend to be very pale. They're an otherwise healthy baby, aside from the fact that they cannot get any nutrition. So luckily this happens pretty early. We're able to see the signs and symptoms, and we're able to take action on it. So we look for the irritable child who has projectile vomiting, usually occurring non-bilious within the first 2 to 4 weeks of life, and then that hard 2 to 3 centimeter movable olive-shaped mass in the right upper quadrant. We also see visible peristalsis occurring in the stomach, and I will show you what that looks like on the next slides. These babies tend to have pretty dry diapers because they're not getting the nutrition they need, so they're not peeing and pooping. We do put them on NPO status, although it's it's not like they can hold anything down anyway, so if we fed them, they just vomit. So preoperatively, we usually start an IV. So we start an IV to give them fluids, and those fluids have most of the time some glucose and some potassium in it, as well as salt. So we might see a D5 half normal saline plus 20 MEQs of potassium. we're going to give these babies as much comfort as we can while we're waiting for the pyloromyotomy, which is the surgical procedure to be done. The comfort that they're going to receive is little drops of sweeties and pacifiers, frequent holding, loving, bouncing. Although some babies, they just want to be left alone because they are so irritable. And that's fine too. Wrap them up nice and tight, give them the good hug in the burrito wrap and IV fluids, put a binky in their mouth, and leave them alone. So they go in for the pyloromyotomy, and it is so fast and easy. And it's one of my favorite things to explain to a parent that they're so worried and they're so freaked out, and their child is looking really unhappy, and they've just not been able to feed, which means the baby's been crying and they've been awake for days and days and days. And they've got the added worry of what they're envisioning as a very complicated, dangerous procedure being performed on their brand new child. So it's nice to be able to explain to them that this is one of the easiest and fastest procedures that can be done in a hospital surgical area. So they go in, they do a little tiny incision right at the epigastrium. They use laparoscopic equipment to just go in, look at it. They stretch out the pylorus and they put a little glue on top of that baby's belly, and that's it. They have maybe a 1-inch scar above their umbilicus, about an inch to 2 inches above their umbilicus, and that's it. It's got glue on it. They come back after 45 minutes usually. 45 minutes. They come back to the pediatric unit, and all we have to do now is get them to basically blow off all of the surgical anesthesia. I usually tell parents to keep the room dark and quiet, keep the sounds down to a minimum. They can change diapers as normal. They can hold, rock, and burp as normal. They don't have to be worried about causing increased pain to the baby. The babies usually guard their own stomachs. They draw their knees up a little bit, and they really like being burped and held and swaddled after this procedure. So if we gave any pain meds, we might only give some oral Tylenol, but usually we don't have to. What they received post-operatively was just enough. So there will be a feeding protocol that we follow, and that feeding protocol is usually it's specific to the physician that did the surgery. So a feeding protocol, for instance, with one of the surgeons at Memorial a gajillion years ago was that when they came back from the operative area, you could, when they were awake and crying and ready, you could give them 15 to 30 mLs of just water. Just water. We usually use the little bottled waters that you can attach the nipple to. So we'll give them 15 to 30 mLs, and then we wait. And we wait to see if they're going to vomit it up. Usually they don't. Then about an hour to 2 hours later, you can give them another 15 to 30 mLs of water. If they don't vomit that up, then you can give them an electrolyte solution. So Pedialyte, they might get a whole bottle of Pedialyte. And then 2 to 3 hours after that, if they haven't vomited it up, then we will give them 30 mLs of formula or breast milk. And then we wait a little longer, we give them the whole bottle of formula or breast milk. If at any point during the feeding protocol they vomit, then we go back to the step before it. It's not like we take them back to surgery. We just give their little guts a little extra time. I have frankly never seen a child who vomited and needed to go back a step. If that happens, and I have heard other nurses explain that their patients have done so, it is related to overfeeding, feeding too fast, feeding too much, not stopping every 15 mLs, and burping appropriately. Okay, so once the feeding protocol has been done and that child is now on ad lib feedings, we can take the IV out and they go home. Typically, they go home within 24 hours. It's a 24-hour hospital stay. The surgery took about 45 minutes total, and that baby is so happy now because they get to finally eat. Now I want you guys to look at these YouTube videos so that you can see the peristaltic waves and what projectile vomiting actually looks like. We have lots of parents who say their children projectile vomit, but they're just spitting up. It's not projectile vomiting. This video is actual projectile vomiting in an infant. And you can see here on this little belly, this is what we typically find post-operatively. This is the little tiny incision that's made and the glue that's put on it. We give parents guidance not to pick at the glue. It needs to just fall off on its own. And they do, like a little wipe down baby bath without soaking the abdomen in bath water until they're able to see the surgeon and get clearance. But I mean, it's a baby. How stinky do they get?